Welcome all. We continue with our treatment for the carcinoma of cervix now. Last session, we have finished with the CIN, then we have finished with the staging of the CS cervix, the pathogenesis, everything we have covered. Now we will discuss about the treatment part. What are the questions which are asked on this particular topic? Discuss the management of the carcinoma of cervix according to the stage. Sometimes they can ask you stage-wise treatment, or sometimes they may give you a particular stage. Stage 1A or stage 1A1 or stage 1B. Man, they can ask you for a specific stage that you need to run. Then discuss the concurrent chemoradiation in carcinoma of cervix. Discuss the fertility sparing surgery in the carcinoma of cervix. Describe the role of radiotherapy in carcinoma of cervix. Okay, so when you are writing about these questions, you have to listen to all previous sessions also and write the points. Okay. Then frequently asked short notes like a radical trachelectomy, then Querleu Morrow classification, Sedlis criteria, concurrent chemoradiation, brachytherapy, pelvic exenteration, radical hysterectomy, cisplatin in cervical cancer. These questions can be asked, and listen to this session till the end. All whatever I have mentioned, you should be able to write these questions. Okay. Coming to the histopathology of the carcinoma of cervix. As per the WHO histological classification, you have different types of carcinoma of cervix. Squamous cell carcinoma is the most common. Then you have adenocarcinoma. Then you have adenosquamous, and then you have neuroendocrine. So these are the four different types. First is a squamous cell carcinoma. That is the most common. Almost 70 to 80% cases, it will be squamous cell carcinoma. Very commonly asked Viva question. Then for subtypes of squamous cell carcinoma like keratinizing squamous cell carcinoma. Commonest is the non-keratinizing squamous cell carcinoma. Then basiloid squamous cell carcinoma, verrucous carcinoma, vortic carcinoma, papillary squamous cell carcinoma, lymphepithelioma like carcinoma. So these are the different subtypes of squamous cell carcinoma. Okay. Then, so squamous cell carcinoma is the commonest histopathological type of carcinoma of cervix. This you should remember. Then adenocarcinoma, the incidence is around 20 to 25%. So 1 in 5 will be adenocarcinoma, 4 out of 5 will be squamous cell carcinoma, and others will be rare. Okay. So in adenocarcinoma also there are certain types. Commonest will be the endocervical type. Then the others are mucinous, endometrioid, clear cell, serous, mesonephric. These are subtypes of adenocarcinoma. Then in you have adenosquamous. Okay, easy to remember. Squamous, adenocarcinoma, then adenosquamous carcinoma. Okay, that is the mixed squamous and glandular differentiation. It has got a worse prognosis than the pure squamous cell carcinoma. Then last is a neuroendocrine tumor. It may be small cell neuroendocrine carcinoma or large cell neuroendocrine carcinoma, and this is highly aggressive. Okay, then histological grading. There are three grades: grade 1, 2, and 3. G1, G2, and G3. That is how it is denoted. Grade 1 is well differentiated. Grade 2 is moderately differentiated. Grade 3 is poorly differentiated. Another important Viva question: what are the poor prognostic histological features? Okay, so when they ask you about histopathology, your answer should be complete. Commonest will be the squamous cell. Other less common are adenocarcinoma, then adenosquamous and neuroendocrine. And pathological features, we suggest the poor prognostic features are LVSI, that is lymphovascular space invasion, then deep stromal invasion, positive surgical margins, lymph node metastasis, parametrial invasion, and large tumor size. So these are the poor prognostic histological features. Okay, lymphovascular space invasion, deep stromal invasion, positive surgical margins, lymph node metastasis, parametrial invasion, and large tumor size. Okay, you should remember this. Okay, now coming to the principles of management of carcinoma of cervix. So management will depend upon, most important is a FIGO stage. Okay, what is the FIGO stage of carcinoma of cervix? Then what is the size of the tumor? What is the lymph node status? What is the fertility desire or the wishes of the patient? What is the age of the patient? And what is the fitness of the patient? Whether the patient is medically fit to undergo surgery or not. So these are the few important factors. Okay, FIGO staging, tumor size, lymph node, fertility wishes, age, and medical fitness. Okay, then treatment modalities. Like any other cancer, we have the same treatment model: surgery, radiotherapy, and or chemoradiation. Okay, chemotherapy and radiation therapy. So surgery. So surgery will be preferred in early stage disease. The patient should be medically fit, and fertility is if that is the main intent, then surgery is the only available treatment with us. Okay, if the patient wants to preserve the fertility, we'll go for fertility sparing surgery. So surgery is suitable for early stage disease when fertility is a concern and patient should be medically fit. Radiotherapy will be preferred for a locally advanced disease, medically unfit patient, and for case of post-operative high-risk disease. Okay, so after the surgery also post-operatively for high-risk disease, we will give radiotherapy. Okay, then coming to the chemotherapy. Usually, it is a concurrent radiotherapy which is given because the drug of choice here is a cisplatin. Okay, this cisplatin is a radiosensitizer. So the dose is a weekly cisplatin, 40 milligram per meter square. Okay, what is the toxicity of the cisplatin? Cisplatin, it is a nephrotoxic drug. Okay, so everything when you are talking in Viva, you should be very fluent. Your chemotherapy, radiotherapy, whatever we have discussed, everything you have to put an answer. Okay, so chemotherapy usually concurrent with radiotherapy. Drug of choice is a weekly cisplatin, 40 milligram per meter square. Now coming to the stage wise management. Okay, so you may be asked a particular stage, or there may be straight away question that describe the stage wise management. Okay, staging we have already seen. So we will go stage wise now. Now stage 1A1. But stage 1A1 for treatment point of view is divided into with LVSI involvement and without LVSI involvement. Okay, that means there is without LVSI means there is no lymphovascular space invasion. That means a good favorable prognosis. Oh, okay. So if you have stage 1A1, that is microinvasive carcinoma, less than 3 millimeter, and there is no lymphovascular space invasion, the treatment option is conization, especially when the fertility is a concern, and others is a simple hysterectomy. Remember, if the patient has completed hysterectomy, go ahead with a simple extrafacial hysterectomy. No need for the radical hysterectomy. This is also Viva question. Stage 1A1 without LVSI. If the fertility is a concern, conization can be done. If it is a patient completed the family, simple hysterectomy can be performed. If it is a LVSI, okay, so stage 1A1 with lymphovascular space invasion, the conization plus negative margins along with the lymph node assessment, or you can go ahead with the modified radical hysterectomy. Okay, though modified radical hysterectomy may be little over treatment, but can still be performed if it is a with LVSI. Okay, but pelvic lymph node assessment according to the risk you have to do with LVSI. Okay, now coming to the stage 1A2. Okay, now stage 1A2 where it is a uh, involvement is a more than 3 millimeter, okay, but less than 5 millimeter. Here preferred is a radical hysterectomy with pelvic lymph node assessment. Okay, and if the patient desires fertility, then you go for radical trachelectomy plus pelvic lymph node assessment. Okay, now how do you do this pelvic lymph node assessment? That also you should know. Okay, so radical trachelectomy plus pelvic. So if you are asked about the fertility sparing surgery for 1A2, your answer will be radical trachelectomy plus pelvic lymph node assessment. Suppose you are asked about the fertility sparing, then you will be writing only about the radical trachelectomy or the conization. Okay, these are the surgeries. Okay, you will not write about the radical hysterectomy. Okay, then stage 1B1. Okay, stage 1B1 is a macroscopic disease. However, the size is less than 2 centimeter. If the patient desires the fertility, then again radical trachelectomy with pelvic lymph node assessment. Okay, now how do you assess the lymph node? You go for sentinel identification of the sentinel lymph node. Sentinel lymph node is the first draining lymph node. Okay, so here for the cervix, the parametrial lymph node will be the first. Okay, then obturator, then internal iliac, then external iliac, common iliac. That is how it will go. Okay, so during surgery, we will inject a tracer around the cervix. So European Society of Gynec Oncologists recommend the endocyanine green, ICG, is the preferred technique. but other alternatives are also available, like blue dye is available. Radiocolloid using technetium 99 can also be used, but this ESGO, that is European Society of Gynec Oncologists, recommend ICG, indocyanine green is the preferred technique. Okay, so with ICG, the ICG will be injected around the cervix, usually at multiple points around the tumor or the cervix. Then this ICG injection, once injected, it enters into the cervical lymphatics. It will travel around the lymphatic drainage, and the first draining lymph node will become a fluorescent. Okay, then the surgeon identifies it using a near infrared fluorescence camera. Okay, so surgeon will identify using infrared fluorescence camera. That then you remove the central lymph node and send it for frozen section. Okay, so you sample this sentinel lymph node. Okay, so even if you do the fertility sparing surgery, you do the this lymph node sampling. Okay, sentinel lymph node sampling. The common pelvic locations include obturator, internal, external iliac, and other pelvic nodal regions. Okay, if the family is complete, then we will go for radical hysterectomy type C1 as per the modern classification, and along with the pelvic lymph node assessment. Alternative is a primary chemoradiation for stage 1B1. Okay, so if it is you are asked about the treatment for stage 1B1, then again you can have a less than 2 centimeter fertility sparing, or if the family is completed. If the fertility is concerned, then go for radical trachelectomy along with pelvic lymph node assessment. If the family is completed, then you will go for radical hysterectomy with pelvic lymphadenectomy. Okay, and alternative is a primary chemoradiation in selected patients. Okay, again fertility is not a concern if you are giving primary chemoradiation. Now stage 1B2, that is 2 centimeter but less than 4 centimeter. Here treatment is a radical hysterectomy with pelvic lymph node assessment. Okay, or another is a concurrent chemoradiation depending upon the tumor characteristics and the institutional policy. Okay, for B3, that is more than 4 centimeter, this is a bulky disease not suitable for surgery. So 1B3, so even if it is a stage 1, that is carcinoma is restricted to the cervix, but if it is a bulky disease more than or equal to 4 centimeter, then go for concurrent chemoradiation because it is a large tumor, higher recurrence after the surgery. Okay, now coming to the stage 2A, again here comes the role of the surgery. Okay, so in 1B3 concurrent chemoradiation, but 2A1 less than 4 centimeter, treatment is a radical hysterectomy or concurrent chemoradiation. So here both options are available with us stage 2A1. Up to here you can go ahead with the surgery except stage 1B3. Okay, then in the initial stages we have seen fertility sparing surgery and family completed. What is the surgery? Okay, now coming to the stage 2A2. Okay, here the size of the tumor is more than or equal to 4 centimeter. Go for concurrent chemoradiation. So in stage 2A1 you can go ahead with the radical hysterectomy, but stage 1A2 and 1B3 no surgery. Okay, and from 1A2 onwards no surgery, concurrent chemo radiation. So stage 2A2 and 1B3. Okay, stage 2A2 more than or equal to 4 centimeter, concurrent chemo radiation is preferred. Then stage 2B, there is a parametrial involvement. Treatment is a concurrent chemo radiation. Surgery is generally not recommended. Coming to the stage 3, 3 is divided into 3A, 3B, and 3C. 3A will be lower one third of the vaginal involvement. Stage 3B will be your involvement of the hydronephrosis will be there, and stage 3C where nodal involvement is there. Stage 3A, the concurrent chemoradiation. 3B, we know that there is a hydronephrosis, hydroureter. Here also treatment is a concurrent chemoradiation, but you will have to treat the hydronephrosis. You will have to add DJ stenting and percutaneous nephrostomy in stage 3B. Okay, because here we know what is involved in the stage 3B, the lateral pelvic wall, the lower one third of the vagina, and this hydronephrosis and kidney. Okay, then stage 3C is a nodal disease. Okay, so nodes are positive, go for concurrent chemoradiation, extended field radiotherapy if paraortic lymph nodes are involved. Stage 4A, treatment is a concurrent chemoradiation, selected patients, pelvic exenteration also. Stage 4B is a metastatic disease. Okay, so here actually palliative treatment is required in stage 4B. You will give systemic chemotherapy, immunotherapy, targeted therapy wherever indicated, palliative radiotherapy, and best is a supportive care. Okay, so uh, in short, stage 1A1 conization or simple hysterectomy depending upon fertility wishes, 1A2 radical hysterectomy, 1B1 radical hysterectomy or radical trachelectomy depending upon fertility wishes, 1B2 radical hysterectomy plus minus concurrent chemoradiation, 1B3 concurrent chemoradiation, stage 1A1 surgery or concurrent chemoradiation, 2A2, 2B, 3 CRT is given, 4A CRT, SOS exenteration, and 4B palliative systemic therapy. Okay. Now we will discuss about fertility sparing surgery. So in which cases fertility sparing surgery can be performed? 1A1 can be performed, 1A2 can be performed up to 1B1. Okay, not after that. Okay, so fertility sparing surgery indication will be young patient, strong fertility desire. You can do this for stage 1A1 with LVSI, 1A2 or selected cases of 1B1 less than 2 centimeter. Okay, and there should not be any nodal disease. Okay, so these are the patients who are suitable for fertility sparing surgery. Now procedures. Procedure first is a conization. This is suitable for 1A1. Then you have a radical trachelectomy. What is removed in the radical trachelectomy? Radical trachelectomy will remove the cervix, the upper vagina, and the parametrium. Remember, what is removed in the radical trachelectomy? Cervix, upper vagina, and the parametrium. But it will preserve the uterus and the ovaries. It is always combined with the pelvic lymph node assessment. This we have already discussed. Even if you do the radical trachelectomy, you will have to do pelvic lymph node assessment. And how it is done? It is done with the help of ICG. Okay. And other options are the blue dye is there, and you have technetium 99 or the radio collide. So these are the other options. So what are the contraindications for radical trachelectomy? If the tumor is more than 2 centimeters, so up to B1 you can go. If the nodes are positive, parametrial involvement is there, and if it is a poor surgical candidate, then you won't go ahead with the radical trachelectomy. Okay, so next is a radical hysterectomy. So what you remove in the radical hysterectomy? You'll be removing the uterus, cervix, upper 1/3 of the vagina, parametrium, and paracolpus. Okay, so cervix, uterus, upper 1/3 of the vagina, parametrium, paracolpus, along with the pelvic lymph node dissection. Okay, so this is what is removed in the radical hysterectomy. Indications will be 1A2, 1B1, selected cases of 1B2, and selected cases of 2A1. Okay, from 2A2 onwards, surgery is not preferred. Okay, so 1A2, 1B1, even 1A2 actually is a aggressive treatment, but 1B1 definitely selected cases of 1B2 and 2A1. Okay, and contraindications 2B onwards. If there is a pelvic side wall disease, if there are distant mates, and if there is a poor performance of the status, that means the patient is not medically fit. Okay, now this is the Querleu Morrow classification for hysterectomy. Okay, so it is divided into A, B, C, D. Okay, A is a as you go from A to D, there is a more and more radical treatment is there. More and more tissues are removed. Okay, so A is a simple hysterectomy. B is a limited parametriectomy. C1 and C2, these are the radical hysterectomy. However, C1 is a nerve sparing radical hysterectomy. C2 is a non-nerve sparing radical hysterectomy. D is a extended radical hysterectomy. Okay, so modern literature uses the Querleu Morrow classification, whereas old previously what we used to mention is a Pever Rutledge Smith classification. Okay, so you should know actually both, and this is the same classification is mentioned over here. Okay, so what we have seen, one is a simple extrafacial hysterectomy. We will have a comparison for these three. Simple extrafacial hysterectomy, then modified radical hysterectomy, and the radical hysterectomy. Okay, so these are the three different types of hysterectomies which are performed in the CA cervix treatment. Okay, now which surgery for which stage and what is done in that surgery. Okay, so if you are asked about the surgical treatment, you should write in this particular format, which makes things very clear. Okay, now simple hysterectomy. Now look at this simple extrafacial hysterectomy. This is Piver Rutledge classification type 1 surgery, or Querleu Morrow type A. Okay, so this is the simple extrafacial hysterectomy. Indication is a stage 1A1. What is removed here? Uterus will be removed, cervix will be removed. Ovaries is optional. Okay, optional removal. Then vaginal margins not removed. So this is like a routine hysterectomy. Okay, so ovaries are not removed, vaginal margins are not removed, ureters are not mobilized, and where the cardinal and uterosacral ligaments are cut, the cardinal and uterosacral ligaments will be cut close to the uterus and the cervical border. So cardinal ligaments are divided at uterine and cervical border, uterosacral ligaments divided at the cervical border. What about the bladder mobilization? Bladder is mobilized to the base of the bladder. Rectum is not mobilized, and surgical approach is laparotomy or laparoscopy or robotic surgery. So this all three surgeries can be done by in this particular way, and we will also have a comparison of laparotomy and laparoscopy further. Okay, in the next discussion. So I hope you have understood what is done in this is routine what we do. Where do we cut the cardinal ligaments? Where we cut the uterosacral? We cut close to the specimen normally. Okay, as you go towards the modified radical and radical hysterectomy, you have to remove, you have to be more radical and remove more of the tissue. The vagina will be removed, then the bladder will be dissected further, then these ligaments, cardinal uterosacral ligaments, will be cut away from the specimen. Okay, so modified radical hysterectomy, that is a Piver Rutledge classification type 2, or Querleu Morrow classification type B. Okay, it is indicated for stage 1A1 with LVSI. Okay, this was 1A1 without LVSI. This is 1A1 with LVSI and 1A2. Okay, uterus and cervix will be removed. Ovaries removal is optional. Okay, vaginal margin, how much vagina is removed here? 1 to 2 centimeter. Okay, then ureter mobilization, here it was not done. Here ureter will be so mobilized tunnel through the broad ligament. So you will be mobilizing the ureter. Then where the cardinal and uterosacral ligaments, so cardinal ligaments will be divided, where ureter will transit the broad ligament. Okay, and uterosacral ligament will be partially removed. Then urinary bladder will be mobilized to the upper vagina. Here it was just mobilized to the base of the bladder. Here it will be mobilized to the upper vagina. Okay, rectum mobilized below the level of the cervix, and the route is same: laparotomy, laparoscopy, or robotic surgery. Now coming to the radical hysterectomy. The radical hysterectomy is a Piver Rutledge type 3. It is type C Querleu Morrow classification, and it is indicated for stage 1B1 and 1B2 and selected stage 2A. Okay, what we remove? Cervix we remove, uterus we remove. Again, ovarian involvement removal is optional. What about the vaginal margin? Here it was 1 to 2 centimeter. Here you remove upper 1/4 to 1/3. So almost 1/3 of the vagina you have to remove. That means you have to separate the bladder further. Okay, here. Then ureter, tunnel through the broad ligament you will dissect. Then where the cardinal ligaments, at the pelvic wall. Okay, so cardinal ligaments will be cut at the pelvic side wall. Okay, uterosacral ligaments near the sacral origin. Okay, then urinary bladder up to the middle of the vagina. Here it was up to the upper vagina, here up to the middle of the vagina, because you have to remove the upper 1/3 to up of the vagina. Okay, so bladder will go to the middle 1/3 of the vagina. Then rectum will be mobilized below the cervix, and the route is same: laparotomy, laparoscopy, or robotic surgery. Okay, I hope you have understood these three types of hysterectomy and in which stage and what we do in each hysterectomy. Okay, now you have to write about the complications of radical hysterectomy. Intraoperatively, there will be hemorrhage, ureteric injury, bladder injury, bowel injury, major vascular injury. Early postoperative complication such as fever, wound infections, urinary tract infection, lymphocyst, deep venous thrombosis, pulmonary embolism. Late complications such as bladder dysfunction, lymphedema, lymphocele, ureteric stricture, fistula, sexual dysfunction, etc. So that was the surgery for the treatment of carcinoma cervix. Now let us come to the radiotherapy. That is the second modality. Here you have to take into account what we have discussed in our previous session on radiotherapy. Here I have not included everything, but the answer will include the combination of both. Okay, so radiotherapy, you know that there is a EBRT, that is external beam radiotherapy, and there is a brachytherapy. Okay, so external beam radiotherapy EBRT will be suitable for primary tumor, parametrium, and pelvic lymph nodes. Okay, it will treat primary tumor, parametrium, and the pelvic lymph nodes. While brachytherapy is essential component of a definitive treatment, and it will deliver high dose radiation directly to the cervix while sparing the surrounding tissues. While EBRT will give to the parametrium also, pelvic lymph node also. But intracavitary brachytherapy, you will get high dose radiation directly to the cervix, but the surrounding tissues will be spared. Okay. So concurrent chemoradiation, where the chemotherapy is also given along with the radiation, because the chemotherapy acts as a radiosensitizer, and the most commonly used drug is a cisplatin. Okay, so standard regime is a EBRT along with weekly cisplatin, 40 milligram per meter square, and you give intracavitary brachytherapy also. So standard regime will include both EBRT, brachytherapy, and weekly cisplatin. Okay, and this is the standard of care for stage 1B3, that is bulky disease more than 4 centimeter. Stage 2, where lower third of the vagina is involved, or the lateral parametrium, but not up to the pelvic wall. Stage 3. Here in stage 3, what are the things which are involved in stage 3? Lower third of the vagina, lateral pelvic wall, and the kidney and the lymph nodes. Okay, stage 4A. Okay, so for this there is a this standard regimen is a CCRT. Okay, now coming to the indications for adjuvant radiotherapy or chemoradiotherapy. Adjuvant radiotherapy, in the sense, primarily we have treated the case for by surgery, but we use radiotherapy as an adjuvant or chemoradiation as an adjuvant. Okay, so if the patient has got high risk features, okay, this also why you should remember what are the high risk features. If there are positive lymph nodes, positive surgical margins, and parametrial invasion, then you will go for concurrent chemoradiation even after the surgery. Okay, then you will go for adjuvant radiotherapy or chemoradiation for high risk features like pelvic lymph nodes, positive surgical margins, and parametrial invasion. And there are intermediate risk factors. These are the Sedlis criteria. Okay, so which are these intermediate risk factors? If it is a large tumor, deep stromal invasion, and LVSI, lymph vascular space invasion. So large tumor, deep stromal invasion, and LVSI are the Sedlis criteria. However, it is not a single one criteria presence. It is the combination of these criteria you have to take into account. So adjuvant pelvic radiotherapy may be considered depending upon the risk profile. Okay, so what we will do post-operatively, we will see the histopathology, and we will see whether she has got a high risk factor or no. So that you will come to know on the histopathology. If there are positive lymph nodes, if the surgically also you have positive margins, and there is a parametrial invasion on the post-operative histopathology, that means she is a high risk. Okay, that means nodes positive, margin positive, parametrial invasion, we will go for adjuvant concurrent chemoradiotherapy. If these factors are not there, then you will assess for intermediate risk factors. These are the Sedlis factors like size of the tumor, stromal invasion, lymph vascular space invasion. Okay, so these are the intermediate factors you will take into account, and it is a combination of these factors will fulfill the intermediate risk criteria. Okay, then you will consider adjuvant pelvic radiation. Okay, now next treatment is a pelvic exenteration. Okay, so up till now we have seen the surgery, radiotherapy, or concurrent chemoradiation. These modalities we have finished. Now next is a pelvic exenteration. Now pelvic exenteration is suitable for which patients? If there is a central pelvic recurrence, but there is no distant mates, the patient is fit, and patient who has received previous radiotherapy. Okay, these patients are suitable for pelvic exenteration. Okay, so previously radiotherapy is received, patient is fit, there are no distant mates, and the recurrence is a central pelvic recurrence. This you should remember when we talk about the pelvic exenteration. It is the central pelvic recurrence and previous radiotherapy who is in a patient who is physically fit. Okay, obviously there should not be any distant mates. So what are the types of pelvic exenteration? The pelvic exenteration may be anterior, posterior, or total. Even if you remember, this is more than sufficient. I don't think that will be expected from you in detail, but anterior, posterior, and total, these are the types of pelvic exenteration. So from examination point of view, radical hysterectomy is preferred for early stage disease. Stage 2B onwards is usually treated with a concurrent chemoradiation. Brachytherapy is essential component of definitive radiotherapy. Weekly cisplatin is the standard radiosensitizing chemotherapy, and fertility preservation is possible only in carefully selected early stage patients. Okay, so this is what is about the treatment. After the treatment, the follow-up. Okay, follow-up of the patient. How will you follow up of the patient? This can also be a viva question. So what are the objectives of follow-up? One, to detect the recurrence early. Second, manage treatment related complication. Third, provide psychological support, assessment of the quality of the life, and counsel regarding sexual health and fertility. Okay, wherever appropriate. So that is what is the objective. So why you want to see the patient after operative again? Because the patient has to have the good quality of life. So you will assess the quality of life. You want to detect the recurrence as early as possible. You have treated either by giving surgery or radiotherapy. So what are the immediate or early complications that you would like? That is why you are following up these patients. So what is the treatment for any malignancy? You remember, for first 2 years, every 3 monthly follow-up, up to 5 years, every 6 monthly follow-up, and after 5 years, it is an annual follow-up. Okay, so up to 2 years, every 3 monthly, from 3 to 5 years, every 6 monthly, and after 5 years, annual follow-up. Okay, so what you are going to do, what is the procedure in every visit? Every visit you will take the history, clinical examination, and investigation. Remember, history, clinical examination, and investigation, that you are going to do in each and every visit. So in the history, you will ask for the vaginal bleeding, discharge, pelvic pain, backache, any swelling on the legs. Okay, urinary symptoms, bowel symptoms, weight loss, etc. We will carry out the general examination, lymph node examination, speculum examination per speculum, and per vaginal and rectovaginal examination we will do. Another important thing as far as carcinoma of cervix is concerned, routine imaging is not recommended in asymptomatic patients. You have staged the disease correctly. You have treated the patient as per the stage. Then routine imaging is not indicated if the patient is asymptomatic. Okay. So you have to follow up the patient. You don't have to follow up the scans. Okay. So imaging investigations are performed only when you suspect the recurrence. Okay. Then you will carry out MRI, CT scan, PET-CT, biopsy of suspicious lesion. So on history and on your clinical examination, if you suspect recurrence, then you advise MRI, pelvis, CT scan, PET-CT, or biopsy of the suspicious lesion. Otherwise, stage-wise treatment is given. Patient is feeling well. No imaging is needed for asymptomatic patients. Okay. Now, when we talk about recurrence, what is the type of recurrence? Recurrence may be local recurrence, it may be regional recurrence, okay, or it may be distant recurrence. So when it is a local, that means either in the vaginal vault, okay, or in the central pelvis, or if you have given a conservative treatment, it may be in the cervix also. You might have given a conization treatment, okay. So either in the cervix, vaginal vault, or the central pelvis, this is the local recurrence. Regional is a pelvic lymph nodes or para-aortic lymph nodes, and distant lung, liver, bone, brain. These are the distant recurrence. So clinically, the patient presentation will be vaginal bleeding, pelvic pain, foul smelling discharge, leg edema, hydronephrosis, weight loss, persistent cough, bone pain, etc. So you will diagnose one by clinical examination, second by MRI, PET-CT, biopsy for the confirmation. Okay. Then how do you manage the recurrence? If it is a, remember, now here certain concept which you have to understand. Management of recurrence. If it is a central pelvic recurrence, and if the patient has received radiotherapy, then you will go for pelvic exenteration. Okay, that means you go ahead with the surgery for pelvic exenteration. It may be anterior, posterior, or what we have discussed. Okay, so you have got a central pelvic recurrence. You will go ahead with the surgery if the patient has received a radiotherapy. That means once you have already given the radiotherapy, further radiotherapy will definitely have the limitation of the dose. Okay, so it is better to go ahead with the pelvic exenteration. Okay, if it is a central pelvic recurrence. Now, if you have treated with the surgery first and there is no pelvic irradiation which is given, then instead of pelvic exenteration, you can give the concurrent chemoradiation. Okay, so if you in the initially you have treated the previous list with a surgery and now there is a central recurrence, then you go ahead with the pelvic concurrent chemoradiation. Okay, now if there are distant meds, if there are distant meds are there, then actually it is a palliative radiotherapy or systemic therapy you can give and best supportive care. So what are the overall prognostic factor for carcinoma of cervix? Good prognostic factors will be early stage of the disease, tumor size less than 2 centimeter, negative lymph nodes, no LVSI, superficial stromal invasion, negative surgical margins, and good physical status of the patient. We have seen the poor prognostic factors. These are the good prognostic factors. Okay. Now, what are the poor prognostic factors? So, advanced FIGO stage, positive pelvic lymph nodes has got a poor survival. Okay, positive pelvic nodes is associated with poor cervical. Then para-aortic nodes has got a worse prognosis. Large tumor more than 4 centimeter, high chances of recurrence. If there is a deep stromal invasion, increased chances of recurrence. LVSI again has got a poor outcome. If margins are positive, high chances of recurrence. Parametrial invasion will lead to advanced disease, and non-squamous histology again not a favorable for prognostic point of view. Non-squamous has got a poor prognosis. Okay, so most important prognostic factor is a FIGO stage. Okay, so earlier the stage, better is the prognosis. So most important prognostic factor is a FIGO stage. If you are asked most important prognostic factor in carcinoma cervix, the answer should be FIGO stage at the time of diagnosis. Okay, now you may be asked some question that the patient is pregnant and she has got a CS cervix, then how will you treat? Okay, so here your question will be answer will be tailored to that particular case, whatever is given to you. If they give with the gestational age, then with respect to that gestational age, with respect to the stage of the disease and the duration of the pregnancy, you will have to write the answer. Okay, so how will you treat the carcinoma of cervix in pregnancy? What are the principles of management? The treatment will depend upon the gestational age, FIGO stage, histology, maternal wishes, viability of the fetus, and it is always a multidisciplinary team discussion. Always, we always have the tumor board meeting before deciding the plan of treatment. Okay, so this all you have to mention either in the viva or in the paper. Okay, so stage 1A1. Now she is a pregnant lady and it is a stage A1A1, that is less than 3 millimeter. Then you can go ahead with the conization. Okay, that means conservative management. Then pregnancy may continue if the margins are clear, and definitive treatment after the surgery if appropriate. Okay, if it is a early overall, if it is a early stage disease, then you can delay the treatment until the fetus is mature, and it may be considered after the counseling, and delivery will be followed by the definitive treatment. So if it is an early stage disease, then you can delay the treatment until the maturity of the fetus, after the counseling. But if it is an advanced disease, then you go ahead with the primary chemoradiation is a standard. Pregnancy management depends upon the gestational age and the maternal priorities. So if it is an advanced disease, say 1B3, where the tumor size is more than 4 centimeter, she will require chemoradiation. Now, if it is a first trimester, chemoradiation is not safe. So if it is more than say 12 to 14 weeks of pregnancy, then you may go ahead with the chemoradiation, provided she is interested in continuation of the pregnancy. Otherwise, it is going to be a termination of the pregnancy for the maternal interest. Okay. So as far as delivery of the patient is concerned, vaginal delivery may be appropriate only in a carefully selected pre-invasive or micro-invasive. So only micro-invasive disease which is locally treated may undergo vaginal delivery. But the invasive carcinoma is an absolute indication for the cesarean section. Okay, so cesarean section is generally preferred when delivery is required before the definitive treatment. Okay, this is a chart which I have taken out from the talk article from the MRCOG. It gives the various stage of the carcinoma of cervix with respect to the gestational age. Okay, so your colposcopy, clinical examination, MRI, ultrasonography, all this you have done, and your stage is either 1A2, okay, that is more than 3 millimeter but less than 5 millimeter, or 1B1, that is less than 2 centimeter. Okay, then you look into the gestational age of the patient. If the patient is less than 22 weeks of gestation, then what you have to do is the pelvic lymph node dissection. Okay, look for the pelvic lymph nodes. If they are positive, then that means it is an advanced case. So you will go ahead with the termination of the pregnancy. Okay, if it is negative, then you go ahead with the delay. You may delay the treatment after the surgery. Okay, or you can go ahead with the simple trachelectomy. So your patient here, you can go ahead with the simple trachelectomy, or you may delay the treatment till the delivery. Okay, if she is 22, more than 22 weeks of gestation, then you can go ahead with the neoadjuvant chemotherapy or delay the treatment at delivery. Okay, so you may delay the treatment or you may go ahead with the neoadjuvant chemotherapy. But if you are giving neoadjuvant chemotherapy, then counseling is going to be very, very important. Okay, then 1B2. Okay, in 1B2, it is more than 2 centimeter but less than 4 centimeter. Then what is the gestational age? More than 22 weeks or less than 22 weeks. If it is more than 22 weeks, that means near towards maturity, then you may delay the treatment till delivery or you may give the neoadjuvant chemotherapy. Okay, so as if it is a more than 22 or viability has crossed, then you can give either of these, NACT or DTAD. That means neoadjuvant chemotherapy or delay treatment. But if it is an early gestation, then you will go for retroperitoneal lymph node dissection. You go ahead with the lymph node dissection, see whether they are positive. Here, this is wrong. Okay, so this negative is here. Once you do the lymph node dissection, if it is a positive, then advanced disease, go ahead with the termination of the pregnancy. If it is a negative, lymph node dissection is negative, then you can give neoadjuvant chemotherapy or delay treatment. Okay. Okay, and if it is less than 22 weeks of gestation, then you can give this NACT or DTAD. Okay, and more than 22 weeks also you can give NACT or DTAD. And here lymph node dissection is negative, then only you can give NACT or DTAD. Okay, and if it is an advanced disease like 1B3, more than 4 centimeter, less gestation, you have option to terminate the pregnancy or neoadjuvant chemotherapy. And more than 22 weeks, again neoadjuvant chemotherapy or delay the treatment because you are more towards the maturity. Okay, so these are the various options which are available. Then what are the complications of treatment? Surgical complications, hemorrhage, infection, bladder injury, ureteric injury, bowel injury, lymphocyte, lymphedema, urinary dysfunction, etc. Radiotherapy complications we have seen actually in detail, but just to enumerate, acute complications like radiation cystitis, radiation proctitis, diarrhea, skin reactions, etc. Late complications like vaginal stenosis, fistula, radiation fibrosis, premature ovarian failure, sexual dysfunction. This all you have to talk in the examination. Chemotherapy, myelosuppression, nausea, vomiting, nephrotoxicity, peripheral neuropathy, etc. Okay. So in recent advances, they can ask you about sentinel lymph node mapping, how it is done. Partly we have discussed before also when we were discussing about early stage treatment, trachelectomy, and at that time we have discussed the sentinel lymph node can be asked. Advantage of the sentinel lymph node mapping is that it will detect the occult nodal metastasis. It reduces the lymphedema chances because you are going to avoid the major surgery. Okay. Then reduces the operative morbidity and increasingly used in selected early stage disease. Okay, so first you do the mapping of the lymph nodes. If it is positive, then you go ahead with the dissection. If it is negative, then you are going to avoid the morbidity to the patient. Okay, then fertility preservation, like radical trachelectomy we have discussed, sentinel lymph node mapping. Okay, improved reproductive outcomes are there. Okay, now, in while comparing the simple hysterectomy, radical hysterectomy, modified radical hysterectomy, we discussed that there are all three modes are available. Laparotomy you can do laparoscopic, you can do the robotic also. Now, what does the trial says? What does the evidence says? So there is a LACC trial, laparoscopic treatment of cervical cancer. Okay, so minimally invasive radical hysterectomy showed inferior disease-free and overall survival compared with open radical hysterectomy for early cervical cancer. So minimal invasive radical hysterectomy. That means you go ahead with the laparoscopic hysterectomy that showed inferior disease-free and overall survival. Okay, so disease-free and overall survival survival was less as compared with the open radical hysterectomy for early cervical cancer. Okay, that means oncological prognosis. There may be advantages of the approach as such from the surgical point of view, early recovery and all. But if you follow up these patients from oncology point of view, the disease-free interval and the overall survival was inferior as compared to the open radical hysterectomy for early cervical cancer. So open radical hysterectomy remains the preferred approach for most women requiring radical surgery. Okay. Now another is a immunotherapy, that is PD-1 inhibitors. Okay, so this can also be asked in the recent advances. Now what are these PD-1 inhibitors? Now what happens now? Normally these cancer cells, the body should destroy these cancer cells identifying as a foreign cells, but what happens, these tumor cells they suppress the normal activity of the T cells because this destruction is carried out through the T cells. But these tumor cells, they have got a certain mechanism by which they suppress this particular activity. So here we use the PD-1 inhibitors such as pembrolizumab or semiplimab. Okay, so these are the immunotherapy PD-1 inhibitors, pembrolizumab or semiplimab. This is used in selected recurrent, persistent, or metastatic disease according to the biomarker status and guideline indications. Normally, what happens? Our T cells will recognize and attack the cancer cells. So T cells will attack the cancer cells. Okay, but these cancer cell normally escape because the cancer cell uses a pathway called PD-1 or PD-L1 pathway. Because what they do, they switch down the T cell response. Okay, so T cell, this response of the T cell for identifying the cancer cell is switched off by because of this PD-1 or PD-L1 pathway. Okay, so this PD-1 the brake is put by the tumor cells. Okay, this brake is put by the PD-1. PD-1 is acting like a brake. So if you give the PD-1 inhibitor, this brake will be released. Okay, so the drug like a pembrolizumab that will blocks the PD-1. Okay, once the PD-1 is blocked, then the brake will be released and T cell will become active and the T cell will attack the cancer cells. Okay, then you have antibody drug conjugate, that is tisotumab vedotin option for selected recurrent metastatic cervical cancer after prior systemic therapy. This is not much expected from you, but if immunotherapy ask, then you should write something about immunotherapy. Okay, especially PD-1 inhibitors. Then there is a precision medicine, biomarker directed therapy, molecular profiling in selected patients. Okay, so in short, we'll just summarize. For management of the carcinoma of cervix, how is the diagnosis? Diagnosis will be done by the biopsy. Then you will carry out investigations such as MRI and other investigations. Then we will do the FIGO staging. Okay, we will identify whether this it is early stage or late stage. Okay, 1A, 2A1. So till that stage, you can go ahead with the surgery. So early stage up to 2A1 except 1B3. Okay, 1A to 2A1 except 1B3, you can go ahead with the surgery. Then adjuvant treatment if indicated. Now when to give adjuvant treatment, that also we have discussed. If it is a locally advanced disease, that is 1B3 to 4A, then concurrent chemoradiation and brachytherapy. If it is a metastatic disease, then it is a systemic therapy and palliative care. Okay, so from examination point of view, persistent HPV infection is the necessary cause. Transformation zone is the site of origin. Biopsy is the gold standard for diagnosis. MRI is preferred for local staging. FIGO stage is the most important prognostic factor. Stage 2B onwards, you have got a concurrent chemoradiation. Then brachytherapy is an essential component of definitive radiotherapy. Radical hysterectomy is preferred for appropriate early stage disease. Open surgery is preferred or minimal invasive radical hysterectomy based on the current evidence, and vaccination does not eliminate the need for screening. Okay, so these same things can be asked in the viva. That is the common histological type of cancer. What are the HPV types associated with carcinoma of cervix? What is transformation zone? What is the clinical importance of this? What is the gold standard for the diagnosis of CS cervix? It is the biopsy. Okay, what is the preferred imaging for local staging? It is the MRI. Okay, then what is the most important prognostic factor? It is a FIGO staging. What is the treatment for stage 2B disease? Okay, so and which radio sensitizing drug you are going to use? What is the role of brachytherapy? What is radical hysterectomy? What are the complications of radical hysterectomy? What is radical trachelectomy? What is the high risk pathological factors requiring adjuvant chemoradiotherapy? What are the Sedlis criteria and their role in adjuvant radiotherapy? What are the late complications of pelvic radiotherapy, pelvic exenteration, and when it is to be done? What is LACC trial and its significance? What is sentinel lymph node mapping? And does HP vaccination replace the cervical screening? No, it does not replace. Okay, so rapid summary: carcinoma of cervix, last minute revision. Etiology is a persistent high-risk HPV infection. HPV 16 is more important than HPV 18. Both are high-risk type. Commonest symptom is a postcoital bleeding. Commonest histology is a squamous cell carcinoma. Cervical biopsy is the gold standard. MRI pelvis is used for local staging. Most important prognostic factor is a FIGO stage. Early stage, that is 1A to 2A1 except 1B3. Surgery is preferred. Then locally advanced disease, that is 1B3 and till 4A, concurrent chemoradiation plus brachytherapy. For metastatic disease, systemic therapy plus minus palliative radiotherapy. For fertility preservation, conization plus radical trachelectomy. Standard radiosensitizer is a weekly cisplatin 40 milligram per meter square. Essential radiotherapy component is a intracavitary brachytherapy. High risk factors: positive lymph nodes, positive margins, and parametrial invasion. Follow-up of the patient 3 monthly for 2 years, 6 monthly till 5 years, and then annually. Okay, so that finishes the topic of carcinoma of cervix. Thank you.